Assalamualaikum and hi everyone. So our group will be presenting the posterior oblique shoulder X-ray, or also known as Crashy view. I am your Nadia Mutrahim and I'll be begin the introducing the clinical context and the reason why this view is so important. So the shoulder is highly mobile and complex joint which is composed of humerus, scapula and clavicle. It is stabilized by the soft tissue like muscle, ligament or tendons, making it prone to a variety of injuries like dislocate and fractures. Standard views like the AP or the lateral shoulder are commonly used in a radiograph. However, the views often fail to clearly visualize the glenohumeral joint space because of overlapping bony structures. That is why the Crashy view is important. It is designed to provide a true AP image of the shoulder by rotating the patient so that the glenoid cavity is seen in profile and free of superimpose. This allows for better visualization of joint alignment, cartilage space, and glenoid ring.
Now, I want to talk about the clinical indication. Firstly, cases of fractures of or dislocation of the proximal humerus, which is the upper part of the arm bone near the shoulder joint. Secondly, fractures of the glenoid labrum or brim, which are part of the scapula that help stabilize the shoulder joint. Thirdly, to assess for a Bankart fracture and to evaluate the integrity of the scapulohumeral joint, which is the main articulation between the scapula and the humerus. Fourth, this examination is also indicated for patients with osteoporosis, a condition that weakens the bone. And lastly, for those with osteoarthritis, a degenerative joint disease that can cause pain and limited movement at the shoulder.
So for the exposure factors, the kVp needs to be around 70 to 80 kVp and the MAS need to be 8 to 12 MAS, which is need to be adjusting depending on the patient's size and the equipment used. The SID need to be 100 to 120 cm and the image receptor size is 24 times 30 cm. It can be used crosswise or lengthwise, which is according to the size of the patient.
Okay, firstly, I will explain about the patient positioning in posterior oblique shoulder X-ray. The patient can be positioned either erect or supine with the affected shoulder placed against the image receptor. The body is then rotated 35 to 45 degrees toward the affected side to properly align the anatomy. It is important that the scapula is positioned parallel to the image receptor to obtain an accurate image. The arm of interest should be slightly abducted with the palm facing forward to ensure optimal visualization of the shoulder structures. This positioning helps demonstrate the glenohumeral joint and related bony landmarks with minimal distortion. However, if a fracture or dislocation is suspected, the patient is usually positioned supine and arm kept in neutral position.
Assalamualaikum warahmatullahi wabarakatuh. My name is Wanda Ilana binti Syafi'i and my matric number is 081559. Now I want to talk about part positioning for shoulder X-ray in posterior oblique projection. First, you have to center the mid-scapulohumeral joint to the central ray and to the center of the image receptor. This is to ensure that the joint is properly aligned and captured at the center of the radiograph. Next, you have to adjust the image receptor or the cassette. The top of the image receptor should be approximately 5 cm above the shoulder and the lateral border of the image receptor should be about 5 cm from the lateral border of the humerus. This placement is to ensure that the entire joint and surrounding structure are within the imaging area. After that, we have to slightly abduct the patient's arm, meaning we have to move it slightly away from the body, but keep the arm in neutral position. That means the palm is facing the body, not rotate inward or
So
upward.
as for the center ray, the X-ray beam need to be directly perpendicular to the image receptor and centered to the scapulohumeral joint, which is about 2 inches or 5 centimeter medial, and also inferior to the superolateral border of the shoulder.
Okay, next I will explain about the breathing instruction in posterior oblique shoulder projection. Okay, the patient is typically instructed to suspend breathing during the exposure. This means the patient should hold their breath after inhaling or exhaling to minimize motion and ensure a clear, high-quality image. Suspending respiration helps reduce blurring caused by chest or shoulder movement, which is especially important for visualizing the joint and surrounding structures accurately. Okay, lastly, for my part, radiation protection during a posterior oblique shoulder projection involves the use of appropriate shielding techniques to minimize patient exposure. A lead apron should be used to protect radiosensitive areas such as gonads and pelvis, especially in younger or reproductive age patients. The shield must be carefully positioned to avoid interference with the primary beam and should not obscure the shoulder region being imaged. If possible and practical, a thyroid shield may also be used, provided it does not interfere with the positioning or diagnostic quality of the image. Additionally, proper collimation and exposure settings should be applied to limit radiation to only the area of interest.
Hi, I'm Sophia. Today, I would like to present about radiographic image appearance. Glenoid cavity are in profile without superimposition of humeral head. The position is scapulohumeral joint space should be open. Anterior and posterior rims of glenoids are superimposed. The humeral head is not overlapping the glenoid as much as a standard AP view. The scapulospine, acromion, and coracoid can be faintly seen depending on angle and build patient.
The next image that we're going to do is the AP oblique Reishi method. This image is in particular looking at the glenohumeral joint, so you're going to have the patient in a rotated position. I'm going to take this marker off because I'm going to actually work on her left shoulder for this image for you. So I'm going to have you just shift over, and this CR is going to be basically directly in that glenohumeral joint, so it's going to be up just a touch from your plain AP shoulder projection. Again, touch the tube, touch the bucky. Make sure that you're realigning this. Every time you move that tube, move the bucky. I can't tell you how many times I failed competencies out of clinical for moving one and not the other. Don't beat me. So, glenohumeral joint is just on the inside of that humeral head. Your rotation for this image is 35 to 45 degrees. And it can be kind of hard to figure out exactly how to rotate that, so the trick that I have is put your hand on the outside of the patient's shoulder and you just kind of let your thumb drop into that joint space, okay? When your thumb drops in, your nail bed, look at where that's directed. That's basically sitting in that joint space. My nail bed right now is coming off at a slight angle towards my patient's opposite side. So I'm going to rotate my patient into the AP oblique position. So right now I'm working on the left shoulder, so she'll end up in LPO position. I rotate that patient till my nail bed is facing out, straight out to my collimator head or to my tube. That is going to make my joint space open. It's going to align my CR parallel with that joint space so it can go through it, and it's also perpendicular to the IR. Okay? So again, starting in AP, hand on the outside of the shoulder, dropping that thumb in. You don't have to squeeze really hard, that just rests in there. Obviously, if somebody has shoulder pain, you're not going to want to be clenching on them. That would be incredibly uncomfortable. So outside of the shoulder, just drop that thumb over and then turn that patient so your nail bed is perpendicular or parallel to the CR, perpendicular to the IR. I'm going to take the affected side's hand and rest it on the abdomen. And this image, because you're only looking for that joint space, you can really collimate in really tightly to just that edge of the humeral head and the surrounding joint space, and I would put a marker right in this light space, the left marker, because the left side's down and that's the side of interest, okay? This is still a 10 by 12 inch cassette, and again, 35 to 45 degrees rotation. It's going to be very patient to patient, but just try that thumbnail trick and that can help you kind of get a gauge of where you're going to want to center and direct your patient.